Welcome to the CME accredited podcast series, Rethinking PC-IOLs, From Evidence to Clinical Decisions. I'm your host, Dr. Jennifer Loh, a cataract refractive surgeon in Miami, Florida, and I'll be in conversation with leading clinical experts exploring the presbyopia-correcting intraocular lens landscape, from preoperative diagnostics and surgical planning to patient communication and financial considerations. Hi, and welcome to our first episode in the series discussing presbyopia, Where Are We Now? And I'm honored to be here today with our guest speaker, Dr. Rahul Tonk, who is a cornea, cataract, and refractive specialist out of New Jersey at the Princeton Eye Group. And he's also an associate professor of ophthalmology at Wills Eye Hospital in Philadelphia. So welcome, Rahul. Thanks for being here.
Thank you so much for having me. I'm excited to be part of this discussion.
Great, thank you. I think that this four-part series is really going to take us through the different parts of presbyopic correcting IOLs, but it would be remiss to not first talk about how impactful presbyopia is in our lives. So, presbyopia happens to everyone at a certain age. And everyone eventually ultimately has cataract surgery. But what's interesting is that only 13% of surgeons routinely offer presbyopia correcting IOLs, despite the evidence of efficacy. Can you tell us a little bit about this?
Yeah, it's really interesting that the utilization of presbyopia correcting lenses has lagged behind what our patients' perceptions are of what a disease presbyopia is. And I think that's had to do a lot with the technology and the comfort of delivering good outcomes with that sophisticated technology, and the ability of showing the value to patients of utilizing or maybe investing in that technology, and managing outcomes of patients who maybe need refinement to get the best or the most out of that technology. So when we have all of those components together, there's a discomfort sometimes amongst surgeons to utilize these lenses, these presbyopia correcting IOLs. And so hopefully we can unpack it. And what we can do as surgeons is meet the demand or the goals that patients have to correct what they see as a disease in some cases.
Perfect. And that leads me to my next question. So, what do you think is the real impact of presbyopia on quality of life and the economic burden? I think historically, 10, 20 years ago, 30 years ago, we just told patients to wear reading glasses. But is this really the right thing to do anymore? Does presbyopia impact patients when they're not wearing their glasses, or when they can wear their glasses, of course, but there may be moments where they can't wear their glasses. So how much of a burden is this on patients?
Well, there's definitely a major quality of life impact. We're talking about a working age population. You hear the stories in the exam lane just as I do of patients that work with their hands, carpenters, architects that are not able to work as efficiently and as smoothly as they had when they were younger, going back and forth with reading glasses, progressives in some cases, and they're looking for solutions. So, clearly, there are folks that are saying, okay, well, I'm going to do monovision contact lenses. I'm going to do multifocal contacts. I'm going to do some form of laser vision correction, what have you. There are many established options for patients at a younger age for the treatment of presbyopia, and those options are very well utilized. Those surgical options included are well utilized. So, the question is, at the time of cataract surgery, are we meeting patients where they are at in terms of wanting to tackle that? But I mean, certainly, patients, we in ophthalmology, of course, we care so much about best corrected visual acuity. And so over time, we've learned, I think, to neglect what a patient's viewpoints are, in the sense that, patients may think about vision as just uncorrected vision, how they see the world. We think very clearly about uncorrected vision and best corrected vision, but that distinction is not apparent to most people all of the time. And so when they cannot read up close, I mean, psychologically, it's very distressing. It's reminding them that they're aging, that they're degenerating, that their lens is not holding up. And in many cases, it's functionally limiting them from being as productive in the workforce as they'd like to be, being as efficient with their computer use, with their ability to go back and forth and send text messages. And of course, for patients that are accustomed even to wearing glasses, let's say for distance, or myopes, now they're into progressive eyeglasses for the first time or trying to lift eyeglasses. The whole thing can get very complicated for our patients and only gets worse when they reach on from their 40s into their 50s, 60s, and into the cataract age.
I absolutely agree. And I think that, especially because you and I are in the age where we're not really presbyopic yet, I think it's tough to understand sometimes. It's not just the fact that, oh, they need glasses to read fine print. Many of them tell me they can't see their food on their plate. That's shocking. So that's a huge burden, not to have any depth perception or range of vision, I should say, or depth of field. And I think that all of us have probably had patients that we nail the distance. They're 20/20. They said they've never seen better for distance in their life. And they understood that they would need to wear reading glasses after surgery. We've educated them on that. But we've probably all had patients that are still really shocked by that loss of range. And it's ironic that some patients with cataracts, even if they're not really that myopic. I mean, we know, of course, if they're myopic, they have near vision, but I've had patients that don't even, they're not that myopic really. But for some reason that cataract is giving them some kind of depth of field. And that goes away when we give them that absolute presbyopia with a monofocal lens, right? And they can be
Absolutely.
more, they're much more shocked than you would realize, some of them at least. So I think
Yeah, certainly.
it's a luxury. Yeah, good. Perfect. All right. Well, that leads us on to the next question. Again, PC-IOLs, the technology is getting so much better. The risk of dysphotopsia is getting better. The optical designs are better. But again, we are having a low adoption. And I think that you've really already addressed a lot of this, but I wanted to know if you had anything else to share, like how to get our audience members to feel more confident about recommending a presbyopic IOL, like with the new advances you've seen, right? Many of us, even 10 years ago or less than 10 years ago, had a lot fewer options in terms of the PC-IOLs, and they weren't really as good, right? So there's a lot of that hangover effect in our community amongst ophthalmologists and optometrists, where there's this negative connotation toward PC-IOLs. But I think you and I have both seen that the advancements have really improved. And how do we get the word out there?
Yeah, my goodness, there's so many parts to it. I think the first thing to say is that, we follow the technology. I think that the presbyopia correcting IOLs of the present are not those of the past. We've gone from refractive IOLs initially to bifocal IOLs with very deep echolets and very clear halos and rings, to trifocal IOLs with very customized, elegantly designed posterior surfaces and hybrid designs, to the category of extended depth of focus lenses and non-diffractive extended depth of focus lenses. And of course, we're seeing continued progress in development amongst our amazing engineers. And what I point out to patients is that when we're talking about the IOLs of today, you can't compare your iPhone 17 in your pocket to your iPhone 1 or 2. This is yes, they're both iPhones, but they're fundamentally different designs and technologies and have different capabilities. And so there's still some hangover, I think, of maybe patients or surgeons having had less than ideal outcomes with some of the earlier technologies that have been improved with optical design, material design. I think real world clinical results have also helped the market move toward what patients actually need, which is more and more functional independence from glasses, not absolute distance to ant-like near vision. And that, I think, adaptation has allowed for industry to kind of prioritize contrast sensitivity and minimizing any kind of dysphotopsias in some of these designs. So, there's definitely been an advancement. And there's so many other pieces to that. We're also much more sophisticated at selecting our patients. in terms of who would do well with a presbyopia correcting lens. And then how do we get patients through the process once they're operated, right? This is not just your standard monofocal IOL that comes out and goes into glasses. In fact, surgery is just the start of the process in many cases, and many patients with presbyopia correcting lenses. So there is, in many cases, a months-long process before implantation and a months-long process after implantation to get the patient the wonderful benefits of these lenses.
I agree with that. And I've heard some of my mentors say it's a year-long journey for a lot of patients, that neuroadaptation and just getting used to their vision. I tell patients that it's different. It's not exactly how you were when you were 21, right? We don't have that exact technology to imitate a true accommodating crystalline lens yet. But I agree with everything you said. We've really overcome a lot. So yeah, I think like you said that there's really three categories of presbyopic IOLs right now: the extended depth of focus, the trifocal or multifocal design, and then the hybrid design to balance that. And I think that, like you mentioned too, halos and glare are probably the number one reason I've heard that surgeons are hesitant to place these lenses. But I think that we have more options now with the EDOF lenses, and I think that the multifocal and trifocal designs, like you beautifully mentioned with the echolets, lowering the step height has really helped with those dysphotopsias. So I think it's time that we take another look at our technology. But yeah, so, I think you've reviewed beautifully. Presbyopia is common. It's nothing that we should ignore. It really impacts the quality of life. And it's something that we as surgeons have a duty and obligation to learn about. Do you have any last words you'd like to share, Rahul? It's been great speaking with you this episode.
Yeah, I think it's very clear that until we have a beautiful, accommodating IOL that maintains contrast and is able to change its shape, that we have designs that, as good as they are, have some trade-offs. They don't break the laws of physics. There are some trade-offs somewhere with respect to contrast sensitivity and with respect to dysphotopsias. And those are two unique things. I think sometimes we over-index on the dysphotopsias, but contrast sensitivity is a huge piece, even for the non-diffractive designs, in terms of delivering a quality, crisp vision. Granted, cataract really reduces contrast sensitivity. And so, patients coming from a cataract to, a presbyopia correcting IOL may not right away recognize what they're not getting in terms of contrast. But as the technology has improved, we're talking about more light utilization in the presbyopia correcting designs. We're not scattering as much light or losing as much light. And so the contrast sensitivity has really improved. Yes, the machining and the echolet design and everything has reduced the density in the bands and the light scatter at nighttime, but the contrast piece of it and the materials design has been phenomenal. We're not breaking the laws of physics, but again, this is, in my view, genuinely a different era of technology. And it's so big credit to the engineers that are making these breakthroughs, I think, and what I like to do as a surgeon, as I counsel my patients, is to say to them, we are surrounded by brilliant people, physicists, optical engineers, and so forth, that work exceptionally hard at improving lens implants, because this is the most commonly performed surgery in the world. And there are so many different companies that work on this, and they're all trying to outcompete each other to put the very best lens in your eye. And me as a surgeon, I'm helpful to you to select the appropriate lens and then deliver the best outcome. But I think framing it in that way helps patients also understand that there are humans involved. There are engineers involved in this process. It is not the surgeon that's handcrafting the lens. And so sometimes when you have this idea of partnership, your surgeon's helping you get the best out of a product rather than your surgeon is selling you a product that she has designed herself. I think that it becomes more of a partnership and improves expectations and I think outcomes.
I think that's very well said. We work the best we can with the best technology we have, but we still can't break the law of physics yet. I love how you say that. So, well, thank you, Rahul, for a great discussion. That brings us to the end of today's episode. Thank you to our audience for listening as well. And I'd like to encourage you to join us on our next podcast or our next episode entitled Diagnostics That Drive Decisions. So we'll be speaking together, you and I as well, later on, Rahul. Thank you again.
Thank you, Jen.
You can explore all episodes in this series, along with additional activities in the full CME accredited program. If you're listening outside the program website, the link is in the show notes.